Bismillahirrahmanirrahim. Hello, everybody. After a quite long absence, we are back again on the same page, discussing one of the most important topics in ICM, tracheostomy and emergencies management. So, today I'm trying to give a quite simple basics about tracheostomy, because tracheostomy on its own is a very large topic. I'm not going to cover the insertion or the long-term weaning plan in ICM, but rather the objectives of today is to discuss the indications of tracheostomy and potential contraindications of trache, and how to choose the tracheostomy tube type and proper size. What about the timing debate? Is doing tracheostomy early better or late, and why? What are the complications of tracheostomy? And then we'll take this to the National Tracheostomy Safety Project NTSP guidelines, discussing the emergencies, guidelines, and algorithms. In the beginning, we need to know the importance of tracheostomy. Having said that, more than 12,000 tracheostomies being done in the UK every year, and this reflects the high number of tracheostomized patients we deal with every day in ICM. So, what are the indications of tracheostomy? The indications of tracheostomy will be one of three categories, usually. Either the upper airway obstruction problem, like the burn patient with smoke inhalation, or massive oropharyngeal trauma, or severe laryngeal edema, like anaphylaxis patient, or extrinsic compression by hematoma, making the intubation is quite impossible, so the tracheostomy will be the magic stuff here. The second indication to facilitate mechanical ventilation weaning. If we have expected prolonged ventilation and we know that patient is going to spend a long time on ventilator, it's not accepted to keep him sedated for a long time. So offering tracheostomy, stop sedation, wake the patient up is the key. The classic example for that is, for example, high C-spine injuries patients. So we just trachea them and stop sedation, wake him up, and start the journey with the physiotherapy and move with the patient forward. The third category, secretion management. All the neurological patients with bulbar problems, with difficulty of swallowings, will struggle with the secretion management, and this would be the reason to offer tracheostomy. Traumatic brain injuries, brainstem lesions, or severe neuropathies like Guillain-Barré syndrome involving the bulbar nerves, or motor neuron disease. So the secretion management could be the reason for tracheostomy. So it would be one of these categories. The contraindications to perform percutaneous tracheostomy is very classic, very well-known contraindication. So first is mechanical ventilation requirement. If the patient is quite high mechanical ventilation requirements, this is a contraindication, because when we perform trachea, you need to deflate the balloon, take the balloon up. There is some time of hypoventilation. So we need the beep to be at least below 8, and the FiO2 below 45%, so we can perform percutaneous tracheostomy safely. Otherwise, this is a contraindication. If the patient has coagulopathy, we need platelets to be at least above 50 to perform tracheostomy. And the PTT ratio and INR should be below 1.5. Otherwise, you need to correct this first before performing percutaneous tracheostomy. The third group of contraindications is something you might find in the local examination. Like if you find the neck hyperextension is difficult, this is a contraindication. A patient with ankylosing spondylitis, for example, a patient with C-spine trauma, So it is impossible to hyperextend the neck, which is very essential to perform percutaneous tracheostomy. So we refer it surgically. Or local infection, or if you scanned the front of the neck by ultrasound and you find a dangerous apparent vessel on your way or huge goiter. So all these cases shouldn't be done percutaneously and should be referred to a surgeon, ENT surgeon or max-fax surgeon, whatever. These are the contraindications of percutaneous tracheostomy. If we decide to perform percutaneous tracheostomy, the next question would be what type and what is the proper size to consider here. On this image, we have the standard tracheostomy, standard lens, cuffed, with supraglottic suction port. And we should use this tube until proved otherwise. It has inner tube and outer tube, cuff, and supraglottic suction port. This is the classic standard one. This is extended lens tracheostomy. We sometimes call it adjustable flange. So you can play with the flange and move it, and you can determine whatever the lens you need inside the trachea. And this is very ideal in patients with deeply seated trachea, morbidly obese patient, or a patient with a neck mass, or a patient with a tracheal stenosis you need to bypass by the tracheal tube. And if you can imagine with a morbidly obese patient, this would be quite dangerous to use the standard type because it might be decannulated easily, accidentally of course, or misdisplaced pretracheal and give a risk of surgical emphysema. So using this one with morbidly obese patient would be more appropriate. This one is a fenestrated tube, and the only benefit of the fenestration is to allow the air during exhalation to go through the larynx vocal cords and give the patient a chance to vocalize and communicate. And of course, we don't start with fenestrated tube in the beginning because it might give the risk of surgical emphysema, especially if these fenestrations outside the stoma or pretracheal. So what we usually do, we can offer the fenestrated tubes later on in the weaning process of the tracheostomy. And last, it could be fenestrated, cuffless or uncuffed, and we usually use this tube for a patient who has already normal swallowing and he can maintain his airway and manage his own secretions. So, but still in need for tracheostomy to stay in. So we just give him the uncuffed tube just to avoid the risk of the tracheal damage by the cuff. That's about the type. The more tricky is to choose the size. And the fact that these tracheostomy sizes are not universally standardized like endotracheal tubes. Endotracheal tube size 7 millimeter means the internal diameter of the tube is 7 millimeter. That's it. In US, in UK, Middle East, everywhere in the world, it is the same. Tracheostomy sizing is not that simple. Every manufacturer has his own system of sizing. And more ridiculously, the same manufacturer might have two different sizing systems for two products of his own. Sometimes the manufacturer do his own sizing based on the internal diameter of the outer tube. But when the inner tube is in, the internal diameter comes less. See this example for Vortex Blue Line Ultra, US. This is American company. Size 8 means the inner diameter of the outer tube is 8, but when we get the inner cannula in, the diameter coming less to 7. So you perform size 8, but the actual internal diameter we ventilate through is 7 millimeter. The same company for other product, Vortex Unipurse, which is the extended lens or adjustable flange one, The sizing system depends this time on the internal diameter of the inner tube, 778899. Same for Tracheotwist, the Germany company. The sizing system depends on the internal diameter of the inner tube. Shiley company, the size doesn't mean anything. It doesn't reflect any real measurement of the tracheostomy. What we need to say here is the size 7 tracho is different from size 7 portix. And both tubes, similar size, but might have very different measurements. And this is very dangerous when you perform downsizing for your tube using different brands. So you need to be very, very careful about this. So what we need to do is to understand the tracheostomy you have in your unit and check the internal diameter of both outer and the inner cannulas, outer diameter, which is important in determining the size, and the total length. Usually, and the rule of thumb, the tracheostomy tube should occupy around 3/4 of the trachea. So the outer diameter for males should be 11. That should be fine. And for females, usually around 10. That will give a rough estimation about the size of the tube you need to use. And now we will go through this usual debate and the famous debate about shall I perform the tracheostomy early or late? And the benefit of doing the tracheostomy early is once you do the tracheostomy, you stop sedation, wake the patient up, and start the physiotherapy early. And this will give definitely less mechanical ventilator days and less ICU stay days. And that sounds beneficial, but on the other hand, you might wait 10 days, 14 days, and offer extubation eventually without offering unnecessary tracheostomy. This study was done and compared the two groups, TrackMan trial 2013, and there was insignificant difference in terms of sedation needs, mechanical ventilation days, and ICU length of stay. But this didn't reflect itself on the mortality. The mortality on 30-day mortality remains the same between both groups. And this conclusion tells us that the decision of making tracheostomy early or late is physician dependent. And actually, it should be discussed on case-by-case basis. Sometimes it's very obvious the patient gonna need tracheostomy, like high C-spine injury, C4, C5 injury, 100% he will need tracheostomy. In this case, doing early better than late. If there is any potential hope that this patient might be extubated in 10 days, 14 days, you should wait and give chance for straightforward extubation rather than offering unnecessary tracheostomy and make the patient stuck with the long-term weaning plans of tracheostomy. So I would say it's still a debate till now. Here we go, the most important slide today, complications of tracheostomy. And when we talk about complications, we usually divide it to immediate complications, which happens during insertion, and short-term, first week or 2 weeks, and long-term complications. When we perform tracheostomy, there would be someone who is performing the upper airway and responsible for the bronchoscopic guidance and the ventilation. And the problem with that guy might cause failure to ventilate and hypoxia. The main performer on the front of the neck, when he's doing puncture or dilatation, he might cause injury to the surrounding structures, vascular structure giving hemorrhage or hematoma, or airway structures giving pneumothorax, pneumomediastinum, surgical emphysema. He might cause also cartilage fracture and the tracheal injury and subsequent surgical emphysema, and this is very difficult to manage. Also, he might insert the tracheostomy tube in the wrong place, pretracheal or transtracheal, into the esophagus. And to be honest, after the bronchoscopic guidance, this is quite rare now. Maybe in the blind technique, but not. It's difficult to perform this with bronchoscopic guidance. Short-term complications could be infections, most commonly stoma site infections. What we usually do here is just to swab the stoma and send it for culture and do the proper care. We might find balloon-related erosions, and that's why we keep measuring the balloon pressure every day, and it should be around 25 to 30. If you have manometer, that should be in the gray zone. It will be colored. So the safe zone is gray colored, green colored, around 25 to 30. If the balloon remains with very high pressure, this causes tracheal necrosis and fistula. Could be tracheoesophageal fistula, or if you can imagine this, tracheoinnominate fistula. Fistula between the trachea and innominate artery with massive hemoptysis. And this, of course, has very high mortality. Other things like occlusions by mucus plugs or accidental decannulation or malposition due to kink or twist, and these two are the most common tracheostomy emergencies and complications: accidental decannulation or malposition and obstruction. And we'll discuss this later on in details. Long-term complications: tracheal stenosis, tracheomalacia, or bleeding. And the bleeding could be anywhere between mild oozing from the stoma up to a massive hemoptysis due to tracheoinnominate fistula. This is an example for the bleeding due to innominate artery tracheal fistula, tracheoinnominate fistula. As you can see, this is massive hemoptysis, is not just ooze, and the only way to fix this might be stenting the innominate artery itself and inflating the balloon and using the tracheostomy balloon as a tamponade, hopefully until the intervention radiology manage stenting the artery if they got time to do that. It is rare, but the mortality is high. The stoma bleed could be from granulation tissue or could be from minor injury of the surrounding vessels due to the insertion itself, and ENT surgeons usually manage this by gauzes mixed with adrenaline or TXA, tranexamic acid. Sometimes they need to do cauterization. Sometimes they take the patient to the theater just to explore the area and do proper repair and cauterization for any minute vessel around causing this oozing. That's about the bleeding. A second complication, another rare complication for tracheostomy, but again difficult to manage, is the surgical emphysema. And as you can see here, this is X-ray. The patient has surgical emphysema on the neck, side of the chest, everywhere, surgical emphysema. And you can see these pectoralis major lines here, reflecting the surgical emphysema. And here, this line of pneumomediastinum as well. All of this air can be due to the tracheal tracheostomy misdisplacement. So displace the trachea in the pretracheal area, causing air escaping to surrounding tissues and causing this surgical tracheostomy. And as mentioned, using short fenestrated tracheostomy, especially if these fenestrations outside the trachea in the pretracheal area, of course this will give surgical emphysema. And that's why we always try to avoid fenestrated tubes, especially in the beginning when we use the positive pressure ventilation, specifically for that reason. How can we manage this problem? Conservative management, and you need to change the tracheostomy if you need to, if it's displaced or in the wrong position. Most likely it would be conservative management. You need to check whether there is associated pneumothorax or not, because it might happen coincidentally, and in this case you need to put a chest drain in to drain the pneumothorax. So when we go back to this slide again, NAP4 report, National Audit Project for 2012, did report that the most common complications from tracheostomy is accidental decannulation or malposition and kink or twist. So the patient with trachea, and he's struggling, he can't breathe, started to desaturate, and they are calling you to manage this situation. How would you manage this situation? For this reason, there was a setup for National Tracheostomy Safety Project, NTSP, and this setup was in 2012, started with 4 critical care consultants, Dr. Brendan McGrath, Dr. Dougal Atkinson, Dr. John Moore, and Dr. Lucy Pates. And after a lot of work, hard work, for more than 3 years, a lot of communication with many bodies like Royal College of Anaesthetists, Intensive Care Society UK, Faculty of Intensive Care Medicine, ENT UK, and other bodies outside the country, they could produce the first national algorithm and the guidelines to deal with tracheostomy emergencies. And here we go. Emergency tracheostomy management. And they give us 2 versions: if the upper airway is patent, or if we don't have upper airway, like laryngectomy patients. So basically, when you face a patient like that, he's struggling, suffocating, desatting, tracheostomy is in, but we are not sure whether it's really in or not, the first thing to do is to call for help. Again, call for help. This is serious emergency. Even if you are airway expert, call for help, because this is an issue which should be managed by 2 expert persons at least. So, look, listen, and feel. Connect the tracheostomy with water circuit, Mabelson C system, and use waveform capnography, please, and try to assess the ventilation. If you can see the chest rise, if you can see positive in tidal CO2, well and good. If not, so this tracheostomy seems not in the right place. What can we do later on? You need to assess the tracheostomy patency. So remove everything might be connected to this tracheostomy. Speaking valve, cap, just remove it. And remove the inner cannula and make sure it's not obstructed. And the test you are going to do is to pass a suction catheter through the tracheostomy. If it's not passing, so this tracheostomy is not in the right place, or maybe kinked, or whatever. So the only way is to deflate the cuff and give chance for the upper airway to ventilate through around the tube. And keep oxygenating the patient from the mouth and from the stoma. If deflating the cuff didn't sort out the problem, so the last resort now is to remove the tracheostomy tube. Just take it out. Don't hesitate. Take it out, because it's useless anyway. And at that point, we have 2 missions now. The first mission is to oxygenate the patient, and the second mission is to secure tube for him. 2 options for oxygenation from the above, using the upper airway. So do your oral airway maneuvers, head tilt, chin lift, jaw thrust, or whatever. Use airway adjuncts and try the bag mask ventilation, and hopefully we can oxygenate the patient or increase the saturation. If this doesn't help, you can oxygenate using the stoma itself, using the pediatric face mask or small eye gel applied directly to the stoma. And when you are in a better situation with mild improvement in saturation, at that point think about the tube. And again, you have two options. You can intubate using the upper airway, or if this is difficult, you can use the stoma for intubation. When you oxygenate using the upper airway, make sure you are covering the stoma very well and ventilate the patient. When you intubate from above, make sure you are using long uncut tube and make sure that the tube tip bypassing the point of tracheostomy, just to avoid air leaks. If this is difficult or failed, so the only option to intubate through the stoma, and this might be doable, especially if the tracheostomy was done more than 7 days ago. And you can use endotracheal tube size 6. You can use smaller tracheostomy tubes. You can use ampuscope. You can fade the ampuscope with the entry catheter and slide the endotracheal tube on the entry catheter, or whatever the technique you're going to use. When you see the laryngectomy patient, the same rules apply, and the only difference is there is no upper airway. You can't use the oxygenation through the upper airway. You can't ventilate through the upper airway. You can't intubate through the upper airway. So the only way you have is using the stoma itself. That's it. But the same rules apply. So first test is to assess the patency by the suction catheter. If it's not going, deflate the balloon and try to oxygenate. If this doesn't help, so just take it out and oxygenate the patient from the stoma. And after you get the patient to a better situation, better sats, just try to intubate the stoma by endotracheal tube size 6 or smaller tracheostomy tube. So the same rules, same steps. The only difference is you don't have upper airway to use for oxygenation or proper intubation. This is references for further reading. And I would strongly advise to go through the National Tracheostomy Safety Project website and have a go on different guidelines they have. Very nice to go through this one. I'm very happy for any question in the comments. Thank you very much.